Hi, everyone, and welcome to another episode of Dr. Gilbert Hosts. We've taken a little break for our summer vacation, and we are back discussing hot topics in Parkinson's disease with our experts. And today we'll be discussing an extremely hot topic in Parkinson's disease, and that is diagnosing Parkinson's disease. You may be aware that there are various tests that are available on the market. There's an imaging test, skin biopsy test, a test of the cerebral spinal fluid, and these can give some information about whether a person does or does not have Parkinson's disease. And we'll be discussing these tests and what, if any, is their role in the clinic today, as well as many other issues regarding diagnosis of Parkinson's disease and how these tests fit into what we already know about diagnosing Parkinson's disease. So it should be a fascinating conversation. And our guest today to help us navigate this important topic is Dr. Marie-Helene Saint-Hilaire, who is a prominent movement disorders physician and a researcher and has been involved in clinical trials regarding testing. So she's an excellent resource to help us understand these new developments. So Dr. Saint-Hilaire will give us a brief introduction, and then we'll get right into answering your questions. So I want you to get those ready. I'd also like to take a moment to thank C&D Life Sciences, who is supporting today's program. I also want to say that we have many guests joining us today. I want to say hello to Craig from Utah, Al from Atlanta, Dale from Cape Cod, hello to Paula and many other people. And I want you to be aware that we may post any comments that you make with the name and or photo that you're logged in with. So please be aware of that. So it's now my pleasure to introduce Dr. Saint-Hilaire to you. Dr. Marie-Helene Saint-Hilaire is professor of neurology at Boston University School of Medicine. She's chief of movement disorders at Boston University Medical Campus and an expert on Parkinson's disease and other movement disorders. She is dedicated to delivering highly specialized and compassionate care to her patients and is a well-renowned Parkinson's disease researcher, having participated in more than 100 research trials, authored more than 100 articles and book chapters, and her research interests include studying new therapies that modify disease progression and symptoms and complications of therapy. She is the director of the APDA Center for Advanced Research at BU, serves on many local, regional, and national movement disorder committees, including APDA's very own Scientific Advisory Board. Welcome, Dr. Saint-Hilaire.
Well, thank you very much for the invitation, Dr. Gilbert. Diagnosing Parkinson's disease, I know how challenging it can be, and I think this will be a great conversation. I have a disclaimer is that I have done research for C&D Life Science and also for the PPMI study funded by Michael J. Fox, and I'm going to discuss results of research done by these two entities today. So we know how challenging it is to make and to receive a diagnosis of Parkinson's disease. It's the way the practitioner presents it to the person really can affect their acceptance of the diagnosis, their acceptance and compliance with treatment. And one of the challenges is when we present a diagnosis of Parkinson's disease is that there's uncertainty about the diagnosis, also uncertainty about the prognosis and the progression of the disease. So that can cause anxiety for the patient and their family. I also have to say that as a practitioner, it is our duty every time we see the person and follow up to re-examine and revisit that diagnosis because it's not necessarily an easy diagnosis. So classically, the way we do we make a diagnosis of Parkinson, and it's still mostly a clinical diagnosis. So it is based on the clinical examination, the presentation, and also the skill and the experience of the practitioner. There are some presentations that are absolutely classical, and usually we don't do tests for that. So if somebody presents, as you see on the next slide, with the classical presentation. So the unilateral tremor, good response to levodopa, and there's no red flag. Usually we don't do any other tests, but there are certain things that we can find from the history or from the examination that raised the suspicion that may not be typical Parkinson's. So if somebody has a lot of falls early on in the disease, some cognitive changes early on, if they seem to progress much more quickly than what we're used to in Parkinson, if they have upper motor neuron signs like increased reflexes or cerebellar signs, which is problems with coordination, a tremor that's more when people use their arms and at rest, and if they don't respond well to levodopa, then really that justifies doing more investigations. We often start with an MRI. That's pretty basic. In certain cases, we might do blood tests. But really, the tests that are more specific for the Parkinsonism are the DaTscan, the skin biopsy, and the seed assay. So I'll start by talking about the DaTscan. So we know that when people are present with symptoms, motor symptoms of Parkinson, that means that about 50 to 60% of the dopamine is decreased in an area of the brain called the striatum. And that's what the DaTscan measures, the decrease in dopamine in the striatum. So it is helpful. It was developed to differentiate between essential tremor and Parkinson's disease, because sometimes the tremor in essential tremor can look like Parkinson. There's a mixed tremor. And it was extremely accurate to diagnose, to make the difference between the two. It also can be helpful in uncertain cases of Parkinson. So very early on in the disease, or if somebody does not have tremor, they have mostly slowness or rigidity. And if they don't respond well to levodopa, you might want to get a DaTscan. It can differentiate also between a primary form of Parkinson and Parkinson caused by medications, because there are medications that can cause Parkinsonism. However, it does not differentiate between the various forms of Parkinsonism. So, as you may know, Parkinsonism is like an umbrella term, and there are various conditions under that umbrella. Parkinson's disease is one. There is also dementia with Lewy body, or DLB, multisystem atrophy, MSA, or progressive supranuclear palsy, PSP. I'm going to use their acronyms because it's too long to say the name of every disease. So it doesn't differentiate between these various forms. The other thing is it's not used for monitoring the progression of the disease, except in research. However, if the disease on if the result on the DaTscan is unclear or equivocal, there are studies showing that if you repeat the test 2 years later, you have better accuracy. But there was a large study, a neuropathological study that was done, it just came out this summer, where they compared the result of the DaTscan in people who had DaTscan to their autopsy. So they had the autopsy result, and they could see if the DaTscan correlated with the autopsy results. So that was a large study published in Neurology in June. This neuropathological study was, in fact, can we have the next slide, please? Oh, yeah, great. So that study showed that really the sensitivity for Parkinson's disease was 100%. So if all the people who were found to have Parkinson's disease on the pathology had an abnormal DaTscan. It also had a negative predictive value for Parkinson's disease of 100%, meaning that if your DaTscan was negative, you didn't have Parkinson's disease. So that's very helpful. However, it again showed that it lacks specificity. So it was also positive in multisystem atrophy and in progressive supranuclear palsy and corticobasal syndrome. It was also positive in certain form of dementia like Alzheimer, frontotemporal dementia, prion disease. And it can be also negative in certain Parkinsonian syndrome like a PSP, corticobasal degeneration, and multisystem atrophy. So it's very important when the doctor orders this test that they understand the limitation of the test. Okay, you cannot over rely on this test to diagnose Parkinson. You have to understand the clinical picture of the patient. Then the next time I want to talk about is the synuclein 1 study. So this was it also very recently published in 2024. It was a study of deposition of alpha-synuclein in the skin. So I'll explain that more in detail, but I just want to show a picture. You show the picture, you see the picture there on how the skin biopsy is done. It's very easy. It's done in the office. It takes a few minutes. I think the worst part of it, the patient tell me, is that, it's the numbing, because you have to numb the area. So that's the worst part of the biopsy. So let's talk about the background, why we think that this biopsy would be useful. So we know that in the brain of people who have Parkinson's disease, pathologically, there is an accumulation of an abnormal protein, misfolded, aggregated alpha-synuclein that forms Lewy bodies when it aggregates in the brain. So that's centrally in the brain. But they also found that this abnormal protein could also be found in the peripheral nervous system, so in the nerves, and particularly the nerves of the skin, which is an easy, place to biopsy. It's so the disease where the alpha-synuclein aggregates are Parkinson's disease, PD, dementia with Lewy bodies, DLB, and multisystem atrophy. There's also another condition called pure autonomic failure, but we're not going to talk about that today. So this study, which was called the synuclein 1 study, was a multi-center NIH-funded study to determine the accuracy and the sensitivity and the specificity of that skin biopsy to diagnose people who have a synucleinopathy. And the method consisted of doing 3 skin biopsies. So they did a skin biopsy in the neck, one in the distal thigh, and one in the distal leg, in people who had a clear diagnosis of a synucleinopathy. So these people had been diagnosed with either Parkinson's disease, DLB, MSA, according to very strict criteria. And the diagnosis was then reviewed by a panel of experts to confirm the diagnosis. And then the biopsies were sent at 2 different labs. And the labs, to be sure that there was concordance, reliability, and reproducibility for the biopsies. And I have a nice little schema or illustration on how this worked when they do the biopsy. I'm waiting. Yeah, let's go the next one, please. Thank you. So they look at the nerve in the skin, and they can use a staining to detect the nerve with something called PGP 9.5. You don't have to worry about that. It's just a staining to find the axon of the nerve. And then they stain for that abnormal alpha-synuclein. And then they merge the images, and you have this, you see the alpha-synuclein in the nerve. And I can show you how it looks like under the microscope. So on the upper left, you see they stained for the axon of the nerve. And on the upper right, they stained for the alpha-synuclein in the skin. And then they merge the 2 images, and they can find the alpha-synuclein in the nerves of the skin. What is also very important is they can quantify the number of nerves terminals they see in the skin, and they can quantify the amount of synuclein they find in the nerves. So we have to talk about the results now. So they had 223 subjects with a synucleinopathy, and 120 controls. And what they found was that the test was over 95% sensitive and specific and accurate to detect a synucleinopathy. So a synucleinopathy is Parkinson's disease, MSA, and DLB. There were some really interesting findings. One was that there were 4 healthy controls, because they were controls that you always compare to controls, that were positive. We don't know what that means. Are these people who will eventually develop Parkinson? That's to be followed. And there are also 10 people who had a clinically diagnosed synucleinopathy who had negative tests. And 7 of these 10 people had Parkinson. So how come? One of the limitations of the study is that we did not take into account the genetic status of the people, especially the people with Parkinson. And we know there are some genetic forms of Parkinson where there's no alpha-synuclein. So did they have one of the genetic forms of Parkinson that does not have alpha-synuclein? So that's something also to be followed. And importantly, there were really minimal adverse events. It was very well tolerated and a safe test. What was also very interesting is that there was a different distribution of the alpha-synuclein depending on the condition. So as you see in PD and DLB, there was most of the alpha-synuclein was really proximally in the neck. Sorry, I talk with my hands a bit. So in the neck, and there were less distally in the leg and the thigh. The people who had DLB had much more alpha-synuclein than the people who had PD. In contrast, the people who had MSA, the alpha-synuclein was deposited mostly distally in the leg. So it is not specific enough maybe to use it as a test to differentiate PD and MSA at the moment, but it certainly is intriguing and is an avenue that needs to be researched. Another finding is that I found personally very helpful for me in clinic is that about 60% of people who have PD or DLB have a small fiber neuropathy in their feet. And that explains why a lot of my patients complain of burning feet. It's related to that. Okay. So in conclusion, the skin biopsy is a very simple, low-risk outpatient procedure. You can do it during a visit in clinic to test for the alpha-synuclein as a biomarker. It very sensitive and specific to detect the synucleinopathies, but it cannot at this point differentiate between the various synucleinopathies. There's research going on that, of course. Because it's it helps with the diagnosis of synucleinopathy. People think that using it to choose patients for research trials, or disease to slow down progression, medication to slow down the progression of the disease modifying therapies. Maybe if we use that test to pick patients, we have a more homogeneous group of patients. And the fact that you can quantify the alpha-synuclein is important. And they found also there might be a correlation between the severity of the disease and the amount of synuclein. So the fact that we can quantify the synuclein in those nerves may be helpful in those trials to monitor disease progression. So the last test I'm going to talk about is the seed amplification assay. It was first developed in 2010 to diagnose Creutzfeldt-Jakob disease, very rare prion disease. But in 2016, they discovered that it could be used to detect alpha-synuclein. And there's been a lot of research on that topic, how we can use that assay to detect synuclein in the blood or in the spinal fluid of people who have Parkinson. In 2023, they reported that they could differentiate the synuclein, the PD from the MSA, which was very important. And in 24, it was proposed as a biomarker for Parkinson's disease and as a basis for a new staging system and a new definition of Parkinson's disease. So the way it works, you see the little drawing on the bottom right, is that you take a biological sample, either spinal fluid or blood, and as I mentioned, there's abnormal aggregated alpha-synuclein in the biological sample, but it's difficult to measure. It's in small quantity. So they mix it with some soluble alpha-synuclein and they incubate them. And the abnormal aggregated alpha-synuclein works a bit like a seed. That's what we call it, a seed amplification assay. So it's like a seed, and the other synuclein sort of like, gets on it, and they get like bigger ball. It amplifies the quantity of those seeds and the size of those seeds, which then can be measured, or it's more easily to measure them. So there was a very large, people might be aware of the PPMI study funded by Michael J. Fox Foundation, where they have thousands of people who are followed and have all kinds of tests, biomarker tests, and DaTscans, and we even do skin biopsies on these people. And they looked at the accuracy or the sensitivity of the seed amplification assay, we call it the SAA, in the spinal fluid of 1,000 participants in this PPMI study. And what they found, if they look at all the Parkinson's disease case, about 87%, it was 87% sensitive. But if you looked at the people at Parkinson and had decreased sense of smell, people we call hyposmic, the sensitivity went up to 97%. Interestingly, if you looked at the people who had Parkinson's disease with a LRRK2 mutation, which is a frequent mutation in Parkinson, or one of the more frequent mutations in Parkinson, they found that it was sensitive only in 78% of the people who had LRRK2 mutation. And it's if you looked at people who had normal sense of smell, it was positive only in 34% of the LRRK2 Parkinson disease who had normal sense of smell. And if you had a normal sense of smell and you were a female, the sensitivity went down to 12%. So just to show you that the genetic status of people is important when we do these tests, this diagnostic test, and also is compatible with the fact that when you do autopsy of people who have Parkinson's disease associated with LRRK2, that significant proportion of these people don't have alpha-synuclein in their brain. And this is the case in other also rarer forms of genetic Parkinson disease. So in conclusion, I just want to mention something about olfaction and hyposmic patients. I was forgetting that they did those tests in people who were at risk of developing Parkinson, who did not have signs of motor Parkinson. And these are people who had only REM behavior disorder, RBD, so they act out their dreams, or they had hyposmia, decreased sense of smell. And what they found was the people who had only RBD without clinical signs of Parkinson, otherwise, about 75% were positive for the seed amplification assay, and about 70% of people were hyposmic. But when you combine both, you looked at the people who had REM behavior disorder and hyposmia, about 93% were positive for that assay. And what was even more interesting was that some of these people who were positive for the assay their DaTscan was normal. They didn't have an abnormal DaTscan, meaning that at that point, the test was sensitive probably to pick up maybe who will develop Parkinson, but the DaTscan was not sensitive. The decrease in dopamine was not sufficient to be picked up by the DaTscan. So it is possible that that test will be positive before the DaTscan is positive. So this is something that is obviously continues to be studied. All right. So in summaries, if we look at all these tests, the all these findings have, how can I say, have led to a new definition, potential definition of Parkinson's disease. And this is really something that is very much used in research, but it's not really useful in clinic yet. So it's not something that a clinician would use. But what is proposed as a new definition of Parkinson's disease is that the term PD refers to people who have a positive seed amplification assay, so positive S, and also signs of dopamine dysfunction by, for example, an abnormal DAT test. So this would be the definition of Parkinson's disease. Some critics say that although it would cover a large fraction of the people who have Parkinson's disease, it doesn't take into account the people who have Parkinson's disease caused by non-synucleinopathy or like genetic disease where the alpha-synuclein is not found. So that's why I say it's very much in discussion, used in research, but it's not ready for clinical use there. So in summary, when the history and the examination are typical, the neurologists do not order extra testing. But if there's something atypical in the exam, we might order MRI, blood test, skin biopsy, and the DaTscan. The DaTscan can help when the diagnosis is uncertain, and it can distinguish if the person has a primary form of Parkinson, but cannot distinguish between the various forms, PD, PSP, MSA, and corticobasal syndrome. The skin biopsy is an accurate test to distinguish PD, DLB, and MSA from the PSP. And MSA may have a specific pattern of deposition of synuclein and the peripheral nerves that will have to be confirmed. The seeding assay seems to be very exciting to detect people who might be at risk of developing Parkinson, who are going to develop Parkinson before they have motor symptoms, and may be helpful to choose people for disease-modifying trials very, very early on before people have motor symptoms. At the moment, these tests are biomarkers, so we cannot use them to monitor disease progression. So what are the future directions? So of course, we want to find a biomarker to monitor progression. That seed assay that has been described in spinal fluid, they want to be sure that it would be reliable as a blood test. That would be much more easy to screen people for Parkinson. Researchers are working on a new staging for Parkinson's disease instead of using the old Hearn and Yahr staging, which is basically based on if you can walk and how is your balance and the motor symptoms. So there's a new staging that is being proposed. We have to compare the skin biopsy test, the DaTscan, the CSF assay as biomarkers. I have the feeling that we might have to combine some tests. Each test has their pros and cons, and I think maybe we might have to introduce genetic testing also as part of the diagnostic tests. It seems to really have an influence on the result of those tests. And finally, I just want to thank Thank you for your attention. And the people I want to thank the most are all the patients and the participants and the controls who've participated in the research and made those discoveries possible. They are the unsung hero, my unsung heroes. So I want to thank you all for participating in research. We couldn't do it without you. Thank you.
Thank you so much, Dr. St. Hilaire. That was excellent information. It has generated many, many questions already. So now it's time for our question and answer portion. So let's jump right in. Terry asks a great question, and this is, I'm going to try to summarize it, which is that Terry had a skin biopsy test, which was normal, but clearly has neurologic symptoms. So movement disorder doctor thought that the disease was related to tau, then went to another doctor who thought maybe these skin biopsy results were not correct. So how do you manage a situation where there's neurologic abnormality, the test was ordered, the test was normal, you think the test is at fault, or the test is giving you important information about the neurologic condition?
Well, yeah, it's that's why you cannot rely only on one test. That's why we might need to combine tests. A DaTscan may be helpful because DaTscan would be positive if the person has general, it's positive if the person has primary Parkinsonism. So maybe her first doctor thought she had a tau disease, which is progressive supranuclear palsy or corticobasal syndrome. And often the DaTscan would be positive. So if the DaTscan is positive, the skin is negative, then you would say, yeah, it could be a tau disease. The skin biopsy test is not 100%. We found that it's very highly accurate, 95%, but it's not 100%. There were some subjects who had, we thought had synucleinopathy who were negative in the study. Would it need to be repeated? It's certainly a possibility, and it's easy to repeat. It's not a really invasive test. And as usual, I'll say also look at the clinical symptoms. Do the examination. It will tell you a lot because tauopathies have other symptoms than the regular Parkinson disease. On examination. Sometimes you can find things on PET scans, can be helpful with the diagnosis, doing a PET scan. And there are certain findings in certain conditions on the MRI. So that's why I think it's not a one test at this point that will give you the answer. It's a combination of tests. You have to take everything together. The
Excellent.
clinical presentation and various other tests.
So let's talk a little bit about the clinical diagnosis, because Glenn asks a great question that I think we really need to highlight, which is, do these tests negate the validity of a clinical diagnosis of Parkinson's? Is that not our gold standard anymore?
No, you still need the clinical diagnosis. Old-fashioned neurologist, the presentation and the examination are very important. And I can tell you that our responsibility as a neurologist is to make the best diagnosis for the patient. And a lot of people come to see me, question of Parkinson, and right at the exam room, I can say, I examine you, you don't have Parkinson or a disease related to Parkinson, because people have ALS, people have myelopathy, spinocerebellar ataxia. So I know, if I do a test for Parkinson, I know it's going to be negative because these people clinically do not have Parkinson. So your primary responsibility is really to make a diagnosis, not that's not Parkinson. What is it now? It's really think about it. This doesn't look like Parkinson. Let's do other tests, or this could be Parkinson, but this is atypical. And what do I want to find? Do I think that I'm not sure it's a primary Parkinsonism, and I just want to screen for just primary Parkinsonism, I probably would do DaTscan. But if I say, oh, this might be a synucleinopathy, is it really PSP versus Parkinson disease? Then I might go for a skin biopsy, or I might do both, depending on the result. So yes, and the clinical picture and how the person progresses and how they respond to medication, you might put them on levodopa and see if they respond. So also help with the diagnosis. So that's why I say the last doctor to see the patient is always the smartest.
Yeah, well said, well said. We have a great question from Bill, and I think this encompasses the questions of many people, which is that this is a particular person who does not meet criteria for Parkinson's, has a father with Parkinson's, but may have some suggestion that something's brewing, like hyposmia or decreased smell, or maybe this person has REM behavior sleep disorder. What do you suggest about testing of such an individual? Would that be even something you would consider? What do you have to say to Bill?
That's a tough question. It's very because we know that hyposmia and REM behavior disorder are risk factors for Parkinson, but not only Parkinson, for other conditions too. We don't know how early these tests become positive. Okay, so we don't, the skin biopsy or the CSF or even the DaTscan. When does it become positive in relation to when your symptoms start? And so even if your test is negative, what does it mean? Okay. What I recommend to people is to sign up for PPMI. They're looking for people who are prodromal, who have REM behavior, or who have a decreased sense of smell. And they will, because it could take 10 years, to develop Parkinsonism or one of these other conditions after you lose your sense of smell, 10, 20 years. So being involved in research like that, first they will do all the tests, and now they're starting to report the results to the subjects, which is very interesting. So not only you participate in research, you do something for research, but you're followed longitudinally by people who know about Parkinson and continue to do those tests. And if new tests, come out, then you'll be involved in that, and they will start to do disease modifying trials early on in people who are at risk of Parkinson. So um, if that person was my patient, I would say, well, let's follow you clinically and see what happens. This could be 10 years before anything happens, but I would encourage them to participate in the PPMI study.
That's a great segue to our next question, which is from Shelley. So Shelley wants to participate in a research study. So what do you suggest? What's the process by which somebody, maybe they're not at a center that is able to connect them to PPMI? What would you suggest that person does to get connected?
Well, there's PPMI has PPMI online. If you're not near a center, they will get you to your visits if you're a good candidate, for the research study. People stay at hotels and so on. They'll pay for transportation. I would, there are various websites where you can go if you're interested in the PPMI study. There you can go to Michael J. Fox Foundation. So there are websites you can connect with them, and there's questionnaires. And if you're good candidates, they would ask you to be in the study. Would you have 3 tests? So the seed amplification assay test is usually not done clinically very much. It's available. You send the spinal fluid to Germany. It's not really covered by insurance. The DaTscan and the skin biopsies are available clinically. Your doctor can order them. Which one I would choose? it really depends what questions they want answered. Okay, so I don't know the specifics. If somebody's on a medication that can cause Parkinsonism, I might want to do the DaTscan because it's an easy way to differentiate. So it really depends which test to do first. Really depends what you're looking for. So I would start with one test, and then depending on what it shows, go to the other test.
Great, that's very helpful. So we have a great question from Sharon, which is what, if you want one of these tests, you feel like your maybe diagnosis is not, doesn't jive with your experience, or there's some reason where you're doubting your diagnosis and you want one of these tests, but your doctor doesn't want to get it for you. Is there something you can do? Is there a way to get these tests if your doctor is resistant?
I don't know, because they have to be ordered by a practitioner, a doctor, or nurse practitioner, or physician assistant. So get a second opinion. I mean, that's the only thing I can say, because it's not like you can go and just have the test like that without somebody ordering it.
Yeah. And I was thinking that maybe, just having a conversation with your doctor about what the resistance is, perhaps it's clear as day to the clinician that this is not in doubt, and maybe trying to explain that, and maybe getting that conversation going is probably the first, maybe the one of something you can suggest to your doctor. So we have a great question from Dale, which is something that you mentioned. You mentioned about the peripheral neuropathy that happens in some of your patients. So Dale is saying his partner had burning sensation in feet 20 years ago, was diagnosed as peripheral neuropathy. It went away without treatment, but now has Parkinson's. So what are your thoughts about peripheral neuropathy and Parkinson's in light of the fact that skin biopsy is becoming something we connect with a Parkinson's disease diagnosis? Any connection there?
Yeah, so I think so. We always discover new non-motor symptoms of Parkinson. I mean, when I was a fellow, we didn't talk about decreased sense of smell and REM behavior disorder as prodromal signs of Parkinson. We were really focused on the motor symptoms. And as time goes on, we discover more and more symptoms that go, that part non-motor signs and symptoms of Parkinson. And I think burning in the feet has, there's so many people who report it. And I do the usual neuropathy workup, and everything is negative. And sometimes it even gets worse when they're off their medication, when they turn off and they take the medicine. It seems to help a little bit. So I think it's part of the disease. I think that small fiber neuropathy is one of the non-motor symptoms of Parkinson. And it can be, maybe it's related to that deposition of the alpha-synuclein in the peripheral nerve. So people are treated symptomatically. You give medication for the neuropathic pain to these people if it's really bothersome. But this is the first time I hear it as a prodromal sign of Parkinson. So I'm very intrigued by that.
Absolutely. Definitely more to learn about that really fascinating topic. But it's true, peripheral neuropathy is so common in the general population, and then you see it so much in people with Parkinson's, and this is a way to maybe think about it differently. So really fascinating. We have a question from Siegel SH, or some way to pronounce that name, that username. Just wanted some clarification on exactly how the biopsies took place when you were doing the research study. Where were the biopsies taken from, and how was the actual procedure done?
Okay, so the biopsy, when we do the skin biopsy test, that's during the study, and what we do in clinic is we have 3 sites. One is the back of the neck, one is the distal thigh, just above the knee, and one is just above the ankle. And you just do some lidocaine, you do a little, a little freeze, go with a little needle. And I heard that's the worst part of the biopsy because it burns a little bit when you freeze. And then you have a little punch punch tool, and you just turn, boop, 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 and you take the little biopsy. You don't even need a stitch. You just put a Band-Aid, a gauze and a Band-Aid on it. And it has to be on it for 24 hours on the side of the biopsy. And then the biopsy is sent through the mail to the CND Life Science. And the way it works is that to be sure it's covered by your insurance, your doctor first fills a form that they send the fax to the company, and the company gets back to them very quickly and say, okay, it will be covered, or it's not covered, or only part of it is covered. So the person knows in advance, how much it will cost. So once you have that information, you do the biopsy. It takes 15 minutes in the office. I mean, it's really easy. And then you put it in an envelope, a special envelope that they supply. You send it to the company, and then the company, about a month later, emails you back with the result, emails the physician back with the result. So they've made it pretty simple to do.
Fantastic. Thank you. So we have another question that people may be thinking about. So if I do pursue one of these tests, like a skin biopsy or the cerebral spinal fluid test, and it's positive, does that change anything that my doctor does for me?
Well,
about these tests.
Yeah. So if you, it depends. I mean, if it changes diagnosis, it might change what your doctor does for you. If your doctor didn't think you had Parkinson, but then the skin biopsy becomes positive, and yes, you do have Parkinson disease, then there's, I mean, first it's good. Some people feel, better knowing what the diagnosis is instead of being in that zone of uncertainty where they don't know exactly what they have. In general, for the treatment at this point, it won't change very much, because if you have a Parkinsonian syndrome, most people anyway will try levodopa. Would the skin biopsy being negative, showing you don't have Parkinsonism, you have more tauopathy, that could maybe say, well, the levodopa may not work, but people will try it anyway. Okay. But other than that, it might not change very much to confirm the diagnosis with the skin biopsies. So if you have a clinical diagnosis of Parkinson, you have a skin biopsy that's positive, or DaTscan that is positive, say, yes, you have Parkinson and you're on levodopa. Yeah, it won't change very much what you're doing.
Okay, that's good to know. So this is something in progress. That,
yes.
Following this over time. Right now, it's looking more like a diagnostic tool. Many practitioners are not using it for this type of reason, or they are pretty sure they know what's going on without any additional testing. But it's always good to know what's on the horizon for the future.
Yeah.
So we have another question. You mentioned somebody who may be on a medication that causes Parkinsonism, and maybe a DaTscan may be useful to sort out whether it's Parkinson's disease or the medication. What about somebody who had a stroke, and their one side is stiff and slow, but maybe there's some suggestion that Parkinsonism is developing? How would you be able to distinguish between symptoms from a stroke and maybe also developing Parkinson's? Would any of these tests be useful for that?
Yeah, I would think it would be useful. And people have a stroke, the DaTscan might not be helpful, because depending on the area of the stroke can affect where the striatum is. I think a skin biopsy would be useful to see if the person has a synucleinopathy. So it won't differentiate between PSP, MSA, and PD, but it will detect it. Well, I mean, if it's negative, it could be PSP, but if it's positive, then probably it is Parkinson's disease or multisystem atrophy. So a skin biopsy could be useful in that case. And then I had a patient like that recently. I couldn't do a DaTscan, and he was on medication that caused Parkinson, and he had a stroke. He had both. And I did the skin biopsy, and it was negative. I was happy to tell him that it wasn't Parkinson.
Great. That's a great anecdote to help us understand that. So you mentioned and people have been asking, you know, I have, let's say, a premotor symptom of Parkinson's, like decreased smell or REM behavior, sleep disorder, acting out dreams. What is the use of a test in that situation? You answered that question about, well, you know, we don't quite know what to do with that type of population right now clinically. What about if somebody carries a gene for Parkinson's, knows that from their family, and is very concerned all the time about developing Parkinson's? Do any of these tests have any value in that situation?
Well, the problem with the LRRK2 is that it's not you know, it's a form of the genetic form of Parkinson where the skin biopsy or even the seed amplification assay will not be useful if it's negative, because a large proportion of these people don't have alpha-synuclein on autopsy. So, but they still could develop Parkinson. The DaTscan, we don't know how early the DaTscan would be positive in that population. So that's also a type of person I would say get involved in a research study like PPMI and get followed recently. And they'll do those tests on you. And you will contribute to the knowledge and help other people so we can answer that type of question. Because there are people who are who carry the gene for LRRK2, but they will never develop the disease. The penetrance is not, you know, there's decreased penetrance. So you can be a carrier without ever getting the disease. So that's why it's important to get involved in research.
Thank you. That's excellent. Thank you. Well, we have time for one last question. So I'm going to ask my own, which is, what do you find? How has your clinic evolved over the last few years? You being very involved in the research of both the PPMI study and also the SYN1 testing that you talked about. Has your practice evolved? What percentage of people do you feel like you do not need a clinical test for, a clinical confirmation for, and what percentage do you feel like you need to use one of these tests? What has been your clinical experience?
You know, most of the people I don't ask tests for, confirmation tests for. So a lot of people are referred to me don't have Parkinsonism. They think they have Parkinson, but I can, you know, say, oh no, this is essential tremor, or this is clearly something totally different. And the people who have Parkinsonism, I would say I would ask a test, confirmation test, maybe in 25% of people, because clinically I feel confident when it's the typical presentation and the examination is totally, you know, clear of other red flags. However, I always mention it to the patient. I always say, you know, I'm pretty clear this really looks like typical Parkinson. I have no concern. But I offer them, I say, if you feel more comfortable, we could do a test to confirm it. And I usually do a DaTscan because it's easier to obtain and to get approval for still at this point. But it's not the majority of patients. Some people say, yes, I would like to have a test. Everybody's different. Some people say yes, and other people say, no, let's wait at the next, how things are going at the next visit. They don't want a test. Everybody's different. So you really to have to take into account the people's preference. I'll say you treat a patient, you don't treat a disease. You really have the discussion with the person.
Excellent. That's really, really helpful. And I think another caveat to that is you can't separate the testing from the practitioner. From someone like you who has a lot of empathy and a lot of knowledge, and putting that all together is really what's important. So I really want to thank you so much for being here and sharing your wisdom and sharing your experience from the research end of it, as well as the clinical end of it. I think that combination is really invaluable. So thank you so much for that fantastic information. And many thanks to everyone for participating in the conversation today. If you know someone who missed today's program, if you joined late, if you'd like to watch this again, this recording will be available on our YouTube channel. So go there and watch it again. And while you're there, subscribe to our YouTube channel so you can watch new videos and live broadcasts. And we can know what kind of programming you like so we can inform our future programming. For additional information and resources, please visit our website at apdaparkinson.org. So before we go, I'd like to tell you about some upcoming APDA programs. So one will take place next week, Wednesday, October 2nd at 2 p.m. Eastern Standard Time. It's entitled Medicare Enrollment, What You Need to Know. So as Medicare open enrollment approaches, this webinar will help provide insights and resources to help you guide your Medicare choices. So please join us next week for that. And at the end of the month, our next Dr. Gilbert host will take place. That will be on October 31st. And we'll be discussing visual changes in Parkinson's with neuro-ophthalmologist Dr. Janet Rucker. So we hope to see you then as well. Be sure to stick around for a few final messages before I go. Thank you again for joining, and we hope to see you soon on another APDA program. Have a great afternoon.
Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.